The hidden culprit, unraveling an uncommon cause of cervical lymphadenopathy. Background: lymphogranuloma venereum (LGV) is a sexually transmitted infection caused by the L1, L2, and L3 serovars of Chlamydia trachomatis. A painful inguinal and femoral lymphadenopathy is a typical sign of the infection. Even though LGV primarily affects the groin, awareness of its rare throat and neck manifestations is crucial for accurate diagnosis and treatment. Case presentation: a 23-year-old male with a history of syphilis presented with a 4-week history of progressively enlarging, painful right cervical lymphadenopathy and subjective fever. The patient reported engaging in unprotected oral sex with multiple partners. Physical examination was unremarkable except for a tender 4 cm neck mass. Extensive microbiological and pathological testing did not yield a diagnosis. Notably, an oropharyngeal swab of Chlamydia trachomatis nucleic acid amplification test (NAT) was also negative. A biopsy showed granulomatous inflammation with necrosis without any identifiable organisms. However, serology revealed antibodies to Chlamydia trachomatis L1. Immunoglobulin A was greater than 1 to 256 and immunoglobulin G was greater than 1 to 1024, identifying an unexpected culprit, oropharyngeal lymphogranuloma venereum (LGV). The patient received a 21-day course of doxycycline, which led to complete resolution of his symptoms. Figure A. Frontal and axial planes of CT neck images demonstrate the 4.3 by 2.1 by 2.9 cm right cervical level 2 heterogeneous lymph node with areas of necrosis throughout. Figure B and C. Mixed inflammatory cells with a predominance of lymphocytes mixed with neutrophils, plasma cells, eosinophils, and macrophages with poorly formed granulation tissue in addition to areas of necrosis, overall suggestive of granulomatous lymphadenitis with necrosis. Discussion and conclusion. Oropharyngeal LGV has been rarely reported in the literature. Presentations vary from asymptomatic carriers to symptoms and signs of pharyngitis, but painful cervical adenopathy was the most common complaint and finding in our review, with fever frequently reported. Misdiagnosis as a pyogenic abscess or tuberculosis lymphadenitis has occurred, leading to incorrect treatment. The gold standard for LGV diagnosis is LGV-specific molecular testing, which is not widely available, and results typically do not come in a time frame that would influence clinical management. Therefore, diagnosis often relies on clinical suspicion, epidemiologic information, and a Chlamydia trachomatis NAT at the symptomatic anatomic site. The sensitivity of pharyngeal Chlamydia trachomatis NAT in males has been reported to be 69%, and it was negative in our case, making the establishment of the correct diagnosis even more challenging. The clinical presentation and positive serology confirmed the diagnosis. This case underscores the necessity of a comprehensive and careful differential diagnosis, ensuring that rare disease presentations are considered to prevent a misdiagnosis.